Dear colleagues and friends, Claudio Conforti here from the Dermatological Research Hospital of Rome. Today I'm going to discuss with you the morphology by body site of basal cell carcinoma. Everybody knows that BCC accounts for 75% of all skin cancer, and usually basal cell carcinoma is considered an indolent cancer, but this is true only when it's treated early and adequately. So to early diagnose basal cell carcinoma is crucial to know its dermoscopic features and body site specific criteria. We are used to classify basal cell carcinoma combining clinical and histological informations. In fact, basal cell carcinoma can be classified according to histology into several subtypes such as nodular, superficial, or morphiform basal cell carcinoma, or according to clinical presentation. Here, for example, you can see several variants: superficial basal cell carcinoma, nevoid, multifocal, sclerosing. However, we know that dermoscopy was a silent revolution in the diagnostic path of basal cell carcinoma because its specificity and sensitivity is higher than 9%. We got used also to split basal cell carcinoma criteria into classical and non-classical criteria. Here you can see some examples of classical criteria such as ovoid nest, leaf-like area, arborizing vessels and ulceration, and examples of no classical criteria such as pink-white areas, multiple erosions. And here you can see the correlation among criterion and histology. For example, classical arborizing vessels are more frequently detected in nodular basal cell carcinoma, while shine white structures are more frequently seen in superficial basal cell carcinoma. And here you can see the criteria: classical arborizing vessels, fine arborizing vessels, short arborizing vessels, and many others. In the last decade, new criteria have been described, such as porcelain structures more frequently detected in morphiform basal cell carcinoma, or white-yellow clots that are sign of invasion of basal cell carcinoma. Among the many criteria, we learned that some of them are more frequently associated with specific variants. For example, multifocal, sclerosing, and infiltrative basal cell carcinoma share common clinical and histopathological features, so they should match together. And the main criteria that we can find in these variants are fine arborizing vessel, porcelain structures, and yellow clots. At the University of Trieste, we perform a study comparing sclerodermiform basal cell carcinoma versus other histotypes to evaluate specific demographic, clinical, and dermatoscopic features, and we saw that superficial basal cell carcinoma shows more frequently upon dermoscopy ulceration and arborizing vessels. Nodular basal cell carcinoma shows globules and nest, while morphiform basal cell carcinoma shows pink-white areas and short vessels. And also the localization is a little bit different. In fact, in addition to the correlation among dermoscopy and histology, several studies prove that some variants of basal cell carcinoma are more frequently detected in specific body sites. For example, superficial basal cell carcinoma is more frequent in younger individuals and in women, and the main localizations are trunk in men and lower extremities in women, while nodular basal cell carcinoma is more frequently detected in older individuals and men, especially on the head and neck area, ear and face in men, eyelid, lips, and neck in women, while morphiform basal cell carcinoma is more frequently detected in adults, and more than 70% of cases are localized on the head and neck area. And here you can see the distribution of basal cell variants according to body site. For example, on the head, you can see that nodular basal cell carcinoma is the more frequent variant. So dermoscopically, the main criteria that we can find are arborizing vessels and ovoid nest. While on the trunk, nodular and superficial basal cell carcinoma are more frequently detected, and here you can see the dermoscopic features such as arborizing vessels and ovoid nest, or pinkish background, ulceration, and short telangiectasias. while on the lower limbs, the superficial basal cell carcinoma is the more frequent variant, but in this area, shiny white structures are very frequently detected. So the appearance of basal cell carcinoma according to body sites is a little bit different, because on the head and neck, classic arborizing vessels are more frequently detected. On the trunk, structureless areas and ulcerations are the more frequent features, while on the lower extremities, polymorphic vessels and short white streaks are the specific criteria of this area. And this is a problem because the dermoscopic features of basal cell carcinoma on the lower limbs are a little bit tricky. In fact, the basal cell carcinoma of the lower limb is considered a chameleon. Here you can see 3 examples of basal cell carcinomas resembling squamous cell carcinoma. Sometimes can be difficult also the differential diagnosis among basal cell carcinoma and melanoma, or among basal cell carcinoma and seborrheic keratosis. And another tricky area is the eyelid, where we can find BCC and intradermal nevus. The main differences are that BCC shows white, bright red in focus arborizing vessels with disruption of eyelashes, while intradermal nevus has a yellow-brown background with the preservation of eyelid. And we perform in a multicenter study from Italian universities, a study comparing basal cell carcinoma and dermal nevi, dermoscopic and localization features, and we proved that obviously the main dermoscopic features of basal cell carcinoma are arborizing vessels, microvessels, ulceration, while for dermal nevi, presence of hair, brown pigment, and comma-shaped vessels are the more frequent features. But we wrote down the localization of basal cell carcinoma and intradermal nevi, and we saw many differences. First of all, the localization, there was a significant difference. For example, nodular BCC is more frequently detected on the lateral part of the forehead, on the dorsum of the nose, on the ala of the nose, while dermal nevi are more frequently detected on the buccal area, perioral region, or on the scalp, while no significant differences there were in the distribution of basal cell carcinoma of the face according to histotypes. So the take-home messages are that the dermoscopic features of basal cell carcinoma can vary according to body site. Obviously, BCCs located on the H zone are high risk of progression. The differential diagnosis of BCC and intradermal nevus on the face can be tricky. The basal cell carcinoma of the lower limbs are a chameleon, and we saw that shiny white structures are the more frequently criterion that we can see here. And if localization and dermoscopic clue do not match, we should consider also another diagnosis. Thank you for your attention. This is part of the team working with me in Rome, and I hope to see you soon.